Well, good afternoon. It's 1:15. I know people are coming in, but the faculty is here. And so I'd like to get started. We have a really good session of speakers this afternoon, focusing on filters and problems with filters and DVT and PE in general. So Dr. Rook is our first speaker, who's going to give us, I'm sure, another innovative talk about concepts and misconceptions regarding chronic venous edema. Thanks, Tom.
I'm not even sure where the inspiration for this talk came from, but when Patty asked me to come up with some stuff, this seemed like something that maybe was a potential worth talking about here. Now, I knew I was going to be the first speaker after lunch. As Patty just pointed out, one of the problems with that is that folks filter in. Let me just give you a little breather as we come into this, and there'll be no conflict here, along with no answers. Like everything I do, this is pretty much just food for thought. I'm going to give you a test question here. Is this a concept that's valid, or is this a misconception? Chronic venous edema is a medical emergency. You guys don't have to use your things. Well, you know, I think that's kind of in the eye of the beholder. I'll tell you a little story here. Back in the day for me, I was taking care of a number of VIP patients, one of whom had just gotten a new personal physician because he had a number of chronic health problems. And this patient had decided to go falcon hunting in the Atlas Mountains of Morocco and had brought his physician with him. And I get a call one morning. This happens to you at the Mayo Clinic sometime. The call I get is, hey, my new patient, who I'm still learning about here, woke up this morning and he's got a hugely swollen hand. I am worried that this may be an acute DVT. Can you come out here to the Moroccan desert and take care of this? So, you know, what do? Well, in my line of work, I actually make house calls like this when necessary. So you work all day, and during the day, between patients, you gather up stuff that you think you might need. And at the end of the day, you catch a flight across the Atlantic. I can't sleep on a plane, so by the time I get to London, you know, I've been awake for like 24 hours. I now needed to meet this fella in Rabat in Morocco. That's where they were going to bring him to meet me. But I missed my flight. I had to take a later flight, and when I did, took off from London to get to Rabat, we flew into what was the largest, most fierce storm to have hit Europe in over 30 years. They had 100 killed in Portugal and flash flooding in this thing. It was horrible. We actually got forced down at the Rock of Gibraltar and were forced to stay on the tarmac, and you can imagine this, the plane was not very pleasant on the inside at that point. Well, the Gibraltarians made us leave the minute it stopped raining, but it was still storming over Rabat. So the pilot said, no problem, I'm going to fly you to Marrakesh, and then you can just get back from there. So that's what we did. And, you know, Marrakesh is a lovely city, but you got to remember, I didn't, you know, by now I'm thinking this guy's hand is probably getting gangrenous at this point. We don't have cell phones. I've been out of communication now for 48 hours. I was supposed to have been there a day and a half ago, and now I'm stuck in Marrakesh. So what are you going to do? Well, I rented a seat on a little minibus that was heading to, and at this point, you know, I sort of smell like Mr. Downey Jr. here, you know, at his arrest report. And I get a little seat in this microbus here, and they're going to take us to Casablanca. So we head out across the African desert. I've got pigs and chickens and goats and stuff breathing down my back. I'm stuck in the middle seat of a 3-seat across thing. On my left is a chain-smoking Frenchman. I hate you. I hate you. And on my right is a Moroccan hooker who's got a big engagement coming up in Casablanca, but she's the only person who can speak English on the whole thing, so she's essential. We drop everybody off at Casablanca. We get to Rabat. I've been awake now for 72 hours. I'm 2 days behind schedule. I look like Nick Nolte now after his arrest. They find me. They take me to the place where I'm going to meet this VIP, and the doc says, oh, you know what? I discovered after I talked to him later that morning that he's had a blocked vein up in his shoulder for 20 years. His hand is always swollen. So 15 minutes later, I'm on a flight back to the U.S. So if anybody wonders if chronic venous edema is an emergency, not for me, okay? I'm going to settle that. Now, at this point, I can tell you about 3 other things that I think are maybe a little bit more germane for you. The first one is this idea right here, that venous obstruction that's, and I've worded it funny here, that's severe enough to cause edema is obvious. Is that true or false? What I mean is if you've got edema and it's caused by venous obstruction, you should be able to find that venous obstruction, right? It should be right there. Look, if you come home and you've got yard edema and it's caused by, some kind of obstruction of your river downstream, you don't have any trouble finding that, do you? Now, sometimes you have to hunt around in certain cases. Yeah, and that's the dirty rat that caused it right there. But there are certain cases of bathroom edema that are caused by obstruction, for example, where you might have to hunt a little harder to find it. But still, you ought to be able to find it if it's there, right? Well, is the same thing true in the venous system? Take this guy here who's got a big swollen arm. If that's due to venous obstruction, one would certainly expect that you'd be able to do a venogram or some test and find that venous obstruction without too much difficulty. It should be obvious. Same is true of edema in the lower extremity caused by venous obstruction. It ought to be obvious. That piece of vein is missing, and everything that's getting back is working its way through those big collaterals. So it ought to be obvious, right? Well, I got a buddy here who says not so fast. This is Dr. Raju. And Dr. Raju has basically made a cottage industry out of finding obstruction in things that don't look like they're obstructed. This venogram down here, if you look at that area, your first thought might be, well, that's wide open. This is in a person who's got some chronic venous edema. But what Dr. Raju has done is perform IVC on a lot of these patients, and he finds that, that he's able to identify a large number of people with venous obstruction by IVC alone, that's the only technique that identifies them. And about half the patients who seem to have symptomatic venous obstruction of the iliac, you need to use IVC to find it. The other tests don't work in his hands. How does he know that it works? Well, he then dilates them and shows that these people's symptoms get better. So that's the way that he makes his statement that, that these things he's finding with IVC are actually important. And he's published, for close to 20 years now on this topic and shown that he's able to remove symptoms in a lot of folks. Now at Mayo, my partners like Harold have not really embraced IVC as aggressively, but we've become a lot more aggressive at using CT scanning to look. And as a result of our aggression in using CT scanning to look for occult blockages in the iliac region on people who otherwise pass their ultrasound, well, I'll just tell you that over the last 5 years, it's led to about a 5-fold increase in iliac stenting procedures. So venous obstruction should be obvious? Misconception. All right, well, let's look at the second one here. It's kind of a flip side of the first one. Severe venous obstruction should cause edema. If any one of you has a bad venous blockage, wouldn't you expect it to cause edema? Well, here's a patient, and I've deliberately picked a venogram because it's an old test. Back in the old days, before most of you guys were around, if you had a DVT, a big one, and you couldn't, for some reason, anticoagulate the patient because they had bleeding problems, this is what we would do. We would go in there and actually ligate the cava, or maybe put a clip on it so that we would close it off. Now, what would you expect to happen to the legs in terms of swelling if I tie off the vena cava? Well, what I always expected to have happen was a patient would come back with gigantic, massive swelling after this procedure. And you know what really happened? Nothing. In the vast majority of patients, clipping or tying off the cava, quite amazingly, just allowed some collaterals to open up, and people got minimal amounts of swelling, like this girl who we tied her cava off. So I think it's a fair misconception to say that severe venous obstruction doesn't always cause readily detectable edema. Just because you got a big clot in some place, you're not going to see edema or other obvious changes. I think we can agree that this idea is a misconception. Now, why am I even bringing it to you guys right now? So what? Well, I'm going to use this as a moment just to remind you of a topic that I know you're going to hear at meetings like this. You're going to hear about this in the future. And that is this new entity that's out there that involves the intracranial and neck vessels, the neck veins. With the advent of MR venography especially, we're finding more and more lesions like this in the head and neck, things that may be due to compression, may be due to old clotting. Sometimes they're positional, but a great period of the time, these are not positional lesions. And no matter how you move the head around, you still have these occult, unexplained venous obstructions. It spawned, again, another industry, the chronic cerebro-sinus venous insufficiency syndrome, CCSVI. And this is again becoming another cottage industry because there's a large group of people, all of whom come to see me, who are convinced that this is a cause of multiple sclerosis. Well, if you know anything about the talks I've given for the last couple days, you know that I only talk about things that are controversial. I have all the questions and none of the answers because this whole CCSVI thing is extremely controversial. Some people think that it's so obvious that, you know, CCSVI for dummies is appropriate, and others think that this thing may be the biggest scam, in history. One thing we could say about it is that it's controversial, but the other thing we can say is that this is a situation where you can have fixed venous blockages and you get no edema or even any other visible signs in many cases. So I'm still trying to figure out what to do about this, and in future meetings, Patty, I'm going to make sure that she gets somebody who's an expert here who'll come and talk about this stuff. All right, well, there's my second big misconception. That brings me down now to my third and final one. If venous edema isn't caused by obstruction, it must be caused by reflux. True or false? I mean, if you've got chronic venous edema and you don't have obstruction, the only way that you're going to have that is with reflux. Well, here's how we normally address this question. Here's my patient comes in with significant edema, and I think this might be venous in etiology. So what do? I call up, I've blinded you on this person's identity, so you'll have no idea who it is. But I go ahead and I get somebody who knows something about radiology, and that person goes ahead and grabs an ultrasound machine, and they say, well, let's find out if they're obstructed. So they do their ultrasound, and they say, nope, there's no obstruction here. Everything's got free flow. So then they stand the patient up, looking for those greater than 500 millisecond reflux periods here, and the patient either does or doesn't have reflux. But if the patient doesn't have reflux by ultrasound and doesn't have obstruction, what do we usually say? Well, I would count on my ultrasound person to tell me, hey, this ain't venous edema. No reflux, no ultrasound. These veins are normal. Go look somewhere else. Let me ask you something. Good one over there. If I had a patient with heart failure and I sent him to you for an echo, I said, tell me if there's anything wrong with this patient. You said, sure, no problem. Here's what I did, Tom. I looked through his heart carefully at the valves, the great vessels, and there's no obstruction anywhere. And then I set my settings for reflux, and I looked to see if there was any valvular incompetence, and there isn't any. So you know what, Tom? This isn't a heart failure problem. This patient doesn't have cardiac disease because they've got no heart obstruction and no reflux. Go look somewhere else. Well, what might we be missing? I realize that'd be a great echo consult, but what might we miss? Well, we'd miss things like reduced ejection fraction from an old infarct or something. We'd miss things like restrictive cardiomyopathy, constrictive pericarditis, a whole bunch of other things that can give us heart failure that don't show up. Well, you know what? If venous edema isn't caused by obstruction, it must be caused by reflux. I think that's a misconception because I think there's a whole bunch of other things besides that cause venous edema, chronic venous edema, like poor muscle calf function, restrictive filling, constriction, compartment syndromes, other kinds of things that are venous in etiology, but they're not obstruction and they're not incompetence. And we miss these. Now, how are we going to assess for them? Remember, I have all the questions and none of the answers. I've been working with plethysmography for years, trying to get a better handle on some of these conditions. And I think there's some things that I can help with, but there are still things out there that we don't test for, and I fear they're relatively common. So, in conclusion, I've given you three things here. Venous obstruction producing edema should be obvious. Well, Dr. Rajou's taught us that that's probably a misconception. That severe venous obstruction should cause edema. I think the CCSVI stuff is going to prove that you can have bad venous obstruction and not have edema. And if venous edema isn't caused by obstruction, it must be caused by reflux. I think we can call that a misconception too. So I'm going to leave you with this thought. We got damn misconceptions. We got the damn causes. This is the damn solution for it right there. Thank you very much.
That's a fantastic talk. Thank you. Let me get oriented here too. So endovascular treatment options for pulmonary embolus is going to be presented to us by Dr. David Gillespie, whom I invited from Rochester in New York. He's a vascular surgeon and quite involved in the entire, educational agenda for DVT in the United States. So thank you for joining us
Thanks,
today.
Betty.
Yeah.
Hard act to follow, Tom. I won't have as many building slides. He's always the pro at that. I will dash a couple of people's hope because I'm going to be just as conservative as Tom, and I'm not going to tell you to go out and be overly aggressive with PE, but I'll try and tell you a little bit of bright news. Those are my disclosures. So you've been hearing a little bit today about venous thromboembolic disease. PE is prevalent. It definitely has a significant morbidity and mortality. Estimated annual incidence, 1.45 per 1,000 person years. It's about 1,350,000 cases per year in the U.S. And I'm going to repeat this term throughout the talk, but the incidence of massive PE approached about 11% in postmortem evaluation of all deaths in one series. 30-day mortality rate for massive PE approaches 30%, pretty significant. And the presence of shock in these patients defines a 3 to 7-fold increase in mortality, with a majority of these deaths occurring within an hour of that onset. So this is something that's urgent. Clive Curon wrote in The Chest in 2008, we know very well how to treat it. Grade 1A recommendations, subcutaneous low molecular weight heparin, unfractionated IV heparin, monitored or fixed dose unfractionated heparin, fondaparinux, and then start warfarin on day 1. Continue the fondaparinux or the low molecular weight heparin for 5 days until the INR is therapeutic, and then continue that warfarin for about 3 months. Put them in graduated compression stockings, and there you have it. But is there more? And who would you do more in? Here's data from the ICOPER study by Sam Goldhaber, published 1999, 2,454 patients with acute PE put into the registry, 52 hospitals, 7 countries in Europe and North America. Primary outcome was all-cause mortality at 3 months. They looked at the prognostic effect of baseline factors on survival, did multivariate analysis, and this revealed things like right ventricular hypokinesis had a much higher mortality rate, 21%, than counterparts with normal RV size and function. That's an important fact that I would ask you to remember. Building from there, this study showed 431 consecutive patients with CT diagnosis of PE. 64% of PE patients had RV enlargement. And again, these patients had higher 30-day mortality than those with normal RVs. And they experienced a higher rate of adverse outcomes compared to patients who had normal RV size. So that really gets us into the risk stratification of patients with PE. You have patients with low, moderate, and high risk pulmonary embolism, and we adjust their treatment strategy accordingly. So again, look for the combination of shock, RV dysfunction, and myocardial injury in your patients with pulmonary embolism, and adjust your aggressiveness accordingly. That's what the data shows. Here's a meta-analysis that pulls together a number of studies really trying to say, well, is there more that we can do? Here they looked at the comparison of thrombolysis with heparin for the initial treatment of pulmonary embolism, and essentially you can see at the bottom the total of it really did not show any difference between the two. In a subgroup analysis, this study, published in 2004, again went back to those patients who were hemodynamically unstable and pulled out 5 trials that included these patients. And when you looked at those patients together, there, the use of thrombolytic therapy was associated with significant reduction in pulmonary embolism or death compared to heparin alone, but no benefits in the trial that excluded these patients. We know, of course, that the PREPIC study, with all its flaws and everything else, it randomly assigned 400 patients who were anticoagulated with proximal DVT and a risk for PE into filter or no filter, and then looked at them over a period of months to years, and they all showed, this is looking at the 8-year follow-up of PREPIC, that symptomatic PE occurred in 6% of the filtered group and 15% of the group without filters, and thereby showing that in that specific patient population that IVC filters did lower the risk of symptomatic PE. But it also occurred at an increased risk of recurrent ipsilateral deep vein thrombosis in the filters that were used in that study at the time. And over a long period of time, really no impact on mortality. I think this is one of the most concerning things we have these days with the exponential use of IVC filters. That really, filters don't do anything to prolong life, et cetera. They do reduce the incidence of pulmonary embolism, but at a cost. So what kind of pharmacomechanical thrombolytic agents do we have that we could use for pulmonary embolism? You have Angiojet, you have Trellis, and you have the EndoWave infusion system. Here's a little bit of data. There's not a tremendous amount of data that's out there in the literature right now. Again, Steve Koo published this data in 2009, a meta-analysis after reviewing Medline and Embase with those inclusion criteria. And with that, he found 35 studies, of which 6 were prospective, 594 patients, and then pooled major and minor procedural complications. 96% of these patients received only catheter-directed thrombolysis, not systemic thrombolysis. And that led to a much lower complication rate of only 2.4%, with a clinical success rate up to 86%. In this study, published in 2008, they report the early and long-term outcomes of patients with massive or submassive acute pulmonary embolism treated with Angiojet, this time using the Expedier catheter, and lumped them into severe, moderate, and mild groups. They looked at technical and procedural successes, obstruction, the Miller indices of lung function, and clinical events. In total, 25 patients, so low number of patients. Majority of them were in the moderate, not in the severe categories. And with that, they could show that their Miller indices of obstruction did decrease in all patients over time significantly. But it does come at some cost. Here's a report of bradyarrhythmias used during Angiojet. We know anyone who uses it a fair amount knows that these patients have neurohormonal release during the period of time. If you take a patient who's got massive PE characterized by hypotension and you cause more hypotension, they can arrest or die. It can be refractory. and basically not the kind of thing you would ever want to do without anesthesia support. I do it usually in the OR with an anesthesiologist, but could be done anywhere as long as you had that kind of support. The other thing about using rheolytic catheters is hemolysis that can occur with current or with excessive use of the aspiration, leading to rheolysis and hyperkalemia and hemoglobinuria. In most of our patients, we've seen a bump in creatinine clearance or decrease in creatinine clearance in the short term, which leads to prolonged hospitalization, of course. So you want to be selective in who you do it in. As such, in the majority of cases, I use a much more benign method of treating patients with massive PE. At least this is my initial weapon of choice, and basically it's percutaneous catheter insertion into the pulmonary arteries and trying to basically just break up the massive PE with rotation of a pigtail catheter. The survival rates of this are 80 to 100%. You don't get any renal failure. You don't get any cardiodysrhythmia. You can inject thrombolytic at the time. It's just more gentle. It's a low-tech method, which is a great initial way to start, and then depending upon the patient's stability, you can escalate it up to something more aggressive. Here you can see pre-fragmentation and post-fragmentation efficacy. You can see shock index goes down, heart rate, blood pressure improve. So it is an effective therapy in many patients. Here you can see a symptomatic massive pulmonary embolism there in the in the right PA extending out. Here's what a pulmonary angiogram would look like, and then do catheter-directed therapy. And this is an ideal situation where you're able to bust it up and regain perfusion. It's not always quite so nicely demonstrated. Here's an example of getting access into one of the pulmonary arteries, and then you could follow that with stiff wire and do angiojet into those. So again, with our levels of evidence, the best level of evidence for treatment of symptomatic massive PE, anticoagulation with heparin should be initiated without delay. Thrombolytic therapy should be used in patients with high-risk PE, cardiogenic shock, persistent arterial hypotension. I also use echocardiography and regional wall motion abnormality. And catheter embolectomy or fragmentation can be used as an alternative to anything else that is efficacious but with a lower level of evidence. Thanks very much.
Thank you, Dr. Gillespie. We have time for a question. Anyone have a question for David? I might have one question. Have you used the vortex? Oh, excuse me.
Question over there.
Yes. Go ahead, Dr. Cooter.
Do you have any information about the other ultrasound accelerated ECOS catheter?
Yeah, I currently do not, but I know that it's out there. I know there's several trials out there looking at ECOS and submassive PE, et cetera. And again, I would go back to, evidence-based medicine. So they need to collect the data and see who benefits from it. There's no doubt, as I always say, I can put a catheter anywhere and infuse anything. The question is, does it really help the patient? Even angiographic clearance of it really is not enough. Those are kind of surrogate markers. You need to see if the patient really benefits from it overall. And the answer to the vortex is no, it's the sexiest kid on the block. It's right now in the hands of our cardiologists and cardiothoracic surgeons who are trying to clean out VADs and the like with it. It's a much larger insertion profile, and I don't really have much else to say.
It's interesting. We did a study a number of years ago, and no one can guess the pattern of embolization. Some big pieces of thrombus embolize and they fragment when they get into the pulmonary bed. They just shatter into 100 little pieces. And some just stack up and become a massive saddle embolus or block one side of the circulation. And it's totally unpredictable. We don't even know from which side most emboli come. It's my guess it's the right side because of the May-Thurner prevalence, but we don't really know, and there's no way to track that. So that being in mind, Dr. Gillespie, do you think that just a CT scan showing the pattern of embolization should be part of an algorithm for whether or not you treat someone, if it's a fragmented type versus the occlusive type?
In short, yes. I think that my main goal is main pulmonary artery embolism. It's really to fragment and cause these massive PEs to go into subsegmental PEs. You're not going to get rid of all the PEs that are there. You're really trying to reduce RV strain and RV obstruction so the patient doesn't arrest.
Okay, any other comments here? Okay, we'll move along here and invite Dr. Bjarnson back to the podium, who's going to talk about IVC filter technology, current and future designs. Thanks, Harold.
Thank you, Patricia. I will be spending approximately the next 15 minutes talking about new advances in the filter technology, but I would like to start off by just reviewing some of the background for filter placement. Before we had access to heparin for treatment of patients with pulmonary emboli, the death rate was over 30%. But with the introduction of anticoagulants, this has dropped significantly. And this is really the basis that we use to help us justify the use of filters. Now, there have been many different means used in the past to accomplish mechanical interruption of the pathway from the source of the thrombus to the lungs, including ligation of the inferior vena cava application and other devices. We had the Hunter balloon, was a balloon inflated in the inferior vena cava to prevent the migration of the thrombus up to the pulmonary arteries. And then we had this silicone membrane that was also placed through a cut down into the jugular vein or femoral vein and then deployed into the inferior vena cava. And all of these devices had a relatively high incidence of complications, thrombosis of the inferior vena cava, migration of the devices, and so on. It was then in 1973 that Greenfield came out with his design, which was based really on oil filters to take crude out of oil pipes. This was initially placed via a cut down into the jugular vein or the femoral vein, but that was in 1984 that the University of Minnesota group introduced the percutaneous way of placing these, and this made this a much easier way of placing cava devices for blockage of emboli, practically places into a percutaneous approach, which it is now entirely. Now, this is just to demonstrate the physiology. The Mobbing-Udding filter was actually placed with the tip facing caudally. If you look at the geometry, if you catch a small thrombus in the Greenfield filter, it will stay at the apex, and the area that you allow for flow in the inferior vena cava is much larger than if you use the first design. Now, that was early realized also that you only needed interruption for a short period of time. And if you look at this picture on your left, this is a device which had a string attached to it. The filter is sitting on the right, but then a ball was buried under the skin in the jugular vein, and this could then subsequently be removed by a cut down when the indication was no longer or didn't anymore exist. This device and similar devices had a large array of complications associated with them and never really panned out. Again, the University of Minnesota group with Kurt Amplatz came out with the first optional or removable device, the Amplatz filter, which was published in 1989. There were certain complications and issues related to that, so this was never made it in the market, but was really the first device that has any resemblance to what we are currently seeing. Now, as we now know, most filters are optional or retrievable, and we have seen a significant increase in the use of filters, which goes along with the introduction of these optional devices. May it be because it is easier and we have a lower threshold to place them now that we know that we can retrieve them, or is it maybe because our indications for trauma and other procedures have also affected this? The fact is that the use of filters has significantly increased, but the retrieval rate has really not followed the rate of increase in filter placement, and these numbers are based on Medicare numbers. I'm going to recite a paper that David Gillespie just cited. Again, the study of 400 patients that were randomized to having filter or no filter, all anticoagulated, and demonstrated a significant decrease in acute pulmonary emboli in the group treated with filters, but it showed no survival advantage over 8 years. And as a matter of fact, and as Dr. Gillespie just demonstrated, as a matter of fact, there was a higher and significantly higher rate of recurrent DVT in the patients that still had filters in at 8 years. Now, turning to my main topic, which was actually to talk about a current new technology. On your left side, you have the well-tried Cook tulip filter. It's a very durable device, has a relatively low complications rate, but it can be difficult to retrieve if it has had some dwell time. On your right side, you have the Select filter, also a Cook product. This is actually a new picture. Just going to cite one article which reported on removal of 120 Select filters, and you can see here that leg penetration, which was the main issue here, was 86%. So, with other words, the legs of the filter extended out of the wall of the cava in over 80% of the patients. And that leads me to the first new development. The Select filter is on its way to the market. They have added hooks and balls to the tip of the filter in order to try to decrease the penetration rate in this device. Now, the barred filter, you can see that we here on this picture 4 iterations of this device, which goes to indicate the difficulties we have had with this filter. It is a very easy device for us in terms of retrieving, but it has had a high rate of fractures and migrations, and each iteration has had some change in its device to try to counter this negative effect. And now, we just recently, this filter has been placed on the market. It has the same basic design, but is made of stainless steel this time, has a slightly stronger force, and the hooks and the feet are designed with it in mind that it will not migrate, and the change in material is probably also done to prevent fractures. This filter has been, this is an ongoing analysis. 88 filters that were attempted to removed, and 97 of those, almost 98%, could be removed. There were no fractures. This is just the time that they had been dwelling before they were attempted removed. There were no fractures, no migrations, and no cava occlusions, which speaks well to this filter now on 5th generation. The Option Elite filter is a filter that has been on the market. Actually, the Option filter has been on the market for probably 5 years. In response to some issues with this filter, it has been redesigned with a stronger hook for us to be able to grab to it, and also change in the hook device, which is supposed to both anchor it in the inferior vena cava and also prevent it from migrating outside of the wall of the cava. Now, this is a new kid on the block, so to speak, here in the United States, even though it's been used for a long time in Europe and in Canada. It is designed similar to all of the other filters that we have seen so far, an open, non-clothed umbrella design with the cone shaped towards the heart along with the flow. It is designed for stability and also to prevent migration as all of the other filters. The pictures on your left side demonstrates the first iteration that was available here in the United States. You had to have a special capsule to be able to retrieve it, but now the newest model, which just recently was released, has a hook at the tip where we can now place a snare around the top, around the tip, and remove it that way. And it's going to make retrieval significantly more easy, I'm presuming. This filter has been in use for a long time, and I just grabbed this one article. Those were 29 filters that had been in for over a year. All of them were successfully retrieved. 2 of them needed some manipulations in order to be able to take them out. There were 27% leg penetrations and no fractures. Now, finally, a very different design. All the filters I have showed you so far have been based on that umbrella, which coating or which clothing you have actually taken away. As I said in the beginning, based on the concept of the oil pipes, how to actually retrieve the crude and or the stones that apparently come in the oil crude and can damage the pumps and things like that. Now we have a filter which is based on nitinol rings and then PTFE netting. I'm not sure if I can get this, but it is deployed. And removed, as you see here in the. Now this is the design again. This is a prospective study that was used for approval between Europe, the United States, and Australia and New Zealand. And they found actually very similar numbers to what we would see with the traditional filters. Few pulmonary emboli, no migrations, easy delivery, and relatively easy removal as well. Finally, I couldn't resist the desire to show this. There are, as you know, for stents, an interest in developing stents that can or will be resorbable or will disappear after they have provided the support that is needed for dissections and stenosis. This has also been tried with filters. In this peculiar example, which was used in animals, they used a C stent from Cook and tied on that a vicryl suture, which is an absorbable suture. There are obviously several issues that need to be addressed, such as what you do with a filter that has a thrombus in it and now is starting to resolve, and there are other issues that you can think of. The short of it is, and what I would like to leave with you is that the indications for inferior vena cava filters are very unclear. We only have one randomized study that has looked at this. I don't see any need for keeping permanent filters that cannot be removed in your armamentary. I think we have very good filters that are optional or retrievable. And as a primary prophylaxis, there are really few indications. Thank you.
Thank you very much, Haraldur. Dr. Greenfield's group showed many years ago that the majority of filters are placed in the last 2 weeks of people's lives in the ICU. And given what Dr. Gillespie said, that mortality doesn't change, Doctor, do you think that there should be any actual change in the filters that we place? I mean, should we intervene here in the ICU placement of filters in the people who aren't expected to actually leave the ICU? Any comments?
My personal view is that filters are grossly overused. It's a huge economical burden for the system. We looked at these numbers as far as charge. If we place and remove a filter, we are talking about charges about $8,000 charges. We do not have any firm evidence that they do help long term.
Dr. Gillespie?
Well, I agree with Dr. Brodersen, and over the last 2 years since the FDA published its warning, the Society for Vascular Surgery and the Society for Interventional Radiology have essentially worked with the FDA and are in the final stages of submitting an IDE to the FDA to collect data on all of the commercially available filters. And in fact, the FDA issued a 522 warning to all filter companies, basically mandating that they do a post-market study or participate in what we're calling this the PRESERVE trial. And I'm proud to say that all of the major filter companies have agreed to participate in the PRESERVE study, except for ALN, which withdrew because its market is mostly European. But if the companies don't participate in PRESERVE or do their own 522, they won't be able to market their filters in the U.S. anymore. So that's going to happen within the next, over the next 5 years.
Dr. Rook?
Yeah, quick question, either Dr. Gillespie or Bjarnason, since you both pointed out the obvious thing about the PRIPEC, that if you have a filter, you cut down your embolus rate by 1/3, but you don't change mortality. How do we explain that? What's the current thinking that, since these are dangerous entities and are responsible for death, how do we cut them down by 1/3 but still have the same mortality?
Well, one of the biggest criticisms with the PREPIC is that all of these patients had filters and were anticoagulated, which in the U.S., a large portion of patients are being treated with either filter or anticoagulation, which of course is not the standard over a long term according to the ACCP guidelines, but in the short term it is. So I think that there's some generalization that the PREPIC does not hold to current filter use, et cetera. And so that could have explained why some improvement in overall mortality overall, because all patients had heparin in that study.
And that could also change with the amount of time you follow the patients, Tom. If it was a short term
Although it goes out to 8
versus
years,
long-term.
though, that's pretty good at that point.
I think we are talking about mortality, but we are not talking about morbidity. So it is quite possible that some of the patients that had pulmonary emboli had morbidity or weren't able to function at the same level as they would they not had pulmonary emboli.
But my point is it could have had nothing to do with the filter.
Sure. No, I think it's a valid point. If everybody's on heparin, It wouldn't surprise me that the
Results were the same.
mortality, yeah, turns out to be the same, so.
And, also Cameron Hari here. Pulmonary embolism, as we know, it's a broad spectrum, just like myocardial infarction. There's the non-fatal and the fatal, and the big ones are the catastrophic ones that people die from. But there are plenty of pulmonary emboli that are probably go undiagnosed as well, because they cause only minor symptoms, or they don't have the they don't cause the instability. So, to me, it's quite conceivable that there's plenty of pulmonary embolisms that are non-fatal, and you would see them as a morbidity, but they won't show up in the mortality statistic.
And as far as I know, the other major morbidity of subsegmental PEs is over long-term pulmonary hypertension and death from pulmonary hypertension, which I don't know that anybody's really, I don't know that data off the top of my head.
That's a good point. Dr. Harry is already sitting at the table. I'd like to invite him to the podium to talk about the cost benefits of all these filters, the risk-benefit ratio, I guess. Thank you very much.
Thank you. So when I was asked to talk about the cost to benefit ratio, or specifically do the benefits justify the cost, of course that's a very daunting and challenging subject when there's no or virtually no good randomized forward-looking data on the subject. So I'll try to do my best, and I think it's a segue from some of the previous discussions and what we're going to be discussing for the rest of the session. Of course, when a physician is doing any kind of invasive procedure or even prescribing a medication, it all depends on who is doing the valuing and what it is that you actually value, right? So when I'm asked, is something worth it? Well, we have to ask, worth what? What is the worth? What are we talking about? Are we talking about dollars? Are we talking about the quality of life or morbidity? Are we talking about hospital readmissions because of financial reasons or because of other burdens to society, to the patient, their family, the work environment, the patient's employers? We're talking about bleeding. We're talking about the short-term benefits of pulmonary embolism reduction. We're talking about the long-term reduction of pulmonary embolism, or are we talking about mortality? Is that what ultimately is of the most value? And then, of course, who is doing the valuing? To the patient, they're the one who's doing the valuing, and they'll be the judge of all those on the left-hand column. Of course, we as physicians, we think that we're the best at valuing what's worth, what is worth it, but that's subjective as well. The hospital and the healthcare system, as we all know, they sometimes have diverging interests from the patient and the doctor and the third-party payers. The device industry, of course, also, they do some valuing also, because if their products are not cost-effective for them and their business model, then they might discontinue it, or they might not try to develop new products that could be better and be more efficacious. And then, of course, Uncle Sam, Medicare, or overseas, whoever the third-party payers might be. These are all the questions that we have to answer, and I don't think I'm going to be able to answer them in the next 14 minutes, but these are the real questions that I think that we have to try to address when we're talking about IVC filters. And just to review some of the data, right? So about 500,000 annual DVTs, okay, and about 1/5 of those are going to be fatal. As fatal pulmonary embolus, and the projected 2012 number was about 260,000 IVC filters in the United States, a huge, huge financial impact if we're just talking about dollars alone. Just to reiterate, there are no currently accepted guideline that would recommend prophylactic use of IVC filters, okay? But what do we all agree on? IVC filters are probably beneficial, both from an effective medical standpoint and a cost-effective standpoint in patients who have venous thromboembolism, not just DVT, but the actual thromboembolus or pulmonary embolus, and cannot receive anticoagulation medications effectively, or those who have clearly defined inability to comply with or tolerate anticoagulation medications. Those we can agree on. Those are not prophylactic use of IVC filters. Those are patients who have actually had a venous thromboembolism. However, we should also recognize that there is no evidence to date that the prophylactic use of IVC filters reduces the venous thromboembolism rate or mortality, the prophylactic use. And I think that if we can agree on these fundamental facts, then we can also agree that they're probably not going to be cost effective if there's no evidence that they're efficacious. prophylactic IVC filters may actually increase the risk of venous thromboembolism. So of course that may place an added burden on the financial costs. Prophylactic IVC filter implantation remains off-label as of today. So as many have tried to do, but never really very effectively, Spangler's group tried to analyze the cost effectiveness of prophylactic versus therapeutic retrievable IVC filters in a high-risk trauma patient population. Of course, trauma patients are a unique patient population, but this is really the only well-defined and good model that has been used to try to determine whether or not there's a cost effectiveness to IVC filter use in prophylactic versus therapeutic filters. Now, this was based on a Markham model, which is a complex statistical model, but they use the different costs projected for implantation of IVC filters, the cost of hospitalization, the cost of anticoagulation, the cost of the CT scans, the cost of complications subsequent to, and then the drawbacks of anticoagulation, hospitalization, and the daily cost of venous thromboembolism. And then, of course, there was an estimation of the cost of death. It was determined that when you use a prophylactic IVC filter for those high risk, what were determined to be high risk venous thromboembolism trauma patients, the cost was slightly worse for those who received a prophylactic IVC filter, and less effective by about 0.14 quality adjusted life years. In the initial hospitalization, the prophylactic IVC filter was determined to be about $3,000 more costly and slightly more cost effective by about 8/10 thousandths of a quality adjusted life year. And the calculation is such that it costs about $380,000 per quality adjusted life year to place a prophylactic IVC filter in a high-risk trauma patient for venous thromboembolism. And currently, we're using $50,000 per quality adjusted life year as an acceptable standard generally across the board. So the efficacy data is truly lacking. We don't really know if it's cost effective, but what actually do we know? Well, as has been discussed and will be discussed further, the PREPIC study was published out to 8 years, and I'm not going to reiterate that. As we have heard, there were 400 patients with DVT who were assessed to be at high risk for pulmonary embolism to receive anticoagulation medications through the duration of the study, either with or without a permanent IVC filter. We'll talk a little bit about the details of the study. The patients were actively screened for PE at baseline and then 8 to 12 days thereafter. DVT was defined only as those associated with symptoms. The baseline characteristics of both groups were roughly equivalent, and this was addressed in our recent panel discussion just a few minutes ago. The IVC filter group and the non-IVC filter group both were to receive indefinite anticoagulation therapy. But as you can see, about 50% of both groups actually consistently received their anticoagulation out to 8 years. And actually the lowest part of the curve was around the 3 to 4 year point, where it was roughly about 45% of patients were actually receiving long-term Coumadin. That obviously confounds the data, because if you have all patients receiving long-term anticoagulation, that might mitigate even more the effectiveness of the IVC filter. Well, in the short run, at 12 days, there was clearly no mortality benefit, but it did seem in the short run for patients with venous thromboembolism that there was a reduction in pulmonary embolism with the implantation of the IVC filter. At 2 years, however, the patients who received the IVC filter did have more DVTs, but there was a non-significant decrease in the pulmonary embolism rate at 2 years, but that was the non-fatal pulmonary embolism. There was no mortality benefit in long-term follow-up in either group. So here we just see in the graphic form that the no filter versus filter at 8 years, the pulmonary embolism rate was decreased for those with a filter, but the filters did seem to portend a higher DVT rate, and there was no difference in the long-term survival of either group at 8 years, and those curves stayed consistently close throughout the study. Well, so who actually does have any mortality benefit from IVC filters, and is that the determination we should use for cost effectiveness? Well, even that we don't really know. But in a retrospective analysis of 38,000 patients, Stein and colleagues were able to demonstrate that really the unstable patients, the hemodynamically unstable patients or the pulmonary ventilated patients, were the ones that would benefit the most from a mortality perspective from implantation of an IVC filter. From this retrospective review, it's about 35% mortality reduction in patients who had an IVC filter in place in the category of patients that were unstable. Stable patients, no matter what their other clinical comorbidities were or how bad you thought the pulmonary embolism was, really didn't demonstrate a mortality benefit in the retrospective review. Well, that raises another question. Are IVC filters even, are they worse? Do they cause morbidities that may be actually worse than having nothing at all? Well, this study was a non-randomized study. This is a retrospective review, as a matter of fact, of about 1,500 patients. But this was a review of patients that were all comers for all indications, and there was no sub-study analysis or risk adjustment model to account for the different illnesses of these patients. These were all comers. At a median of 926 days, the all-cause mortality was actually higher in the IVC filter group for all comers. That may be because the patients who got the IVC filters were sicker in the first place, but we don't know. Subsequent DVT was higher in the filter group, and subsequent pulmonary embolism did not demonstrate any significant variance between the two groups. So this is just food for thought, that IVC filters, whether or not we place them because patients are sicker or because they're actually making patients sicker, is still an unanswered question. Now, the question for the future is, and we might discuss this in a little bit in the next discussion, is does it matter what kind of filter you put in, and not necessarily what the configuration of the filter is, but is a retrievable filter better than a permanent filter? It would seem that if the long-term benefit is not seen, and actually keeping an IVC filter in the long run might actually cause more DVTs and morbidity, then maybe a retrievable filter would be a prudent thing. A retrospective series by Kim and colleagues of 427 patients who received a retrievable IVC filter versus permanent IVC filters were followed out to almost a year. The pulmonary embolism rate was about the same. The DVT rate was about the same, and the IVC thrombosis rate was about the same. So we just still don't have a very clear answer on this subject. Well, then, I guess through the past 10 minutes or so of speaking, I've left you with data that's clear, makes us clear as mud. So then the next question is there any hope for us to gain any insight into this issue in the future? Well, hopefully the National IVC Filter Registry will help clarify some of these issues for us. The cost effectiveness data will come afterwards, obviously, once we determine whether or not there's any real true clinical benefit from placing an IVC filter in patients who aren't the most unstable patients. And PREPIC 2, of course, will help to give us future guidance as to whether or not a retrievable IVC filter will be more cost effective and more beneficial in terms of efficacy than permanent filters. The increased use of IVC filters is not supported by any high-quality evidence, as I think is demonstrated and going to be reiterated throughout the session today. The only indication for IVC filters that are widely accepted are in patients with venous thromboembolism who cannot be anticoagulated or are in the most unstable patients. And further research is needed to determine which patient population outside of these criteria may benefit from IVC filters in the future. Thank you for your time.
Sure. Anybody have a question for Dr. Harry? Yes, go ahead. Speak up, please. The question, can I repeat the question so people can hear it? Or can you repeat your question with the mic, please?
One place we've used prophylactic, and the only place I've really seen it are unstable PE patients, and we've used retrievable filters in those cases and removed them within 30 days. And those patients have also either gotten catheter-directed thrombolysis and have been anticoagulated as well. Is that someplace that these filters may be beneficial?
So that specific scenario, I think, is one of the most justifiable use of an IVC filter in a patient who has actually, it's not actually prophylactic now in the definition that I was discussing, because the patient had a venous thromboembolism and a PE. So this is well, IVC filters are not therapeutic, but it's not actually a prophylactic application. And retrieving IVC filters is a major issue in the implantation, right? We place retrievable IVC filters, but only about 30 to 50% of IVC filters that are actually retrievable, that are implanted, are actually taken out in the United States. Okay, so if you're going to place one for the short-term risk of pulmonary embolus, to reduce that short-term risk, and the patient demonstrates that they can be anticoagulated in the long term for whatever is believed to be the appropriate time frame for that patient, whether it be as little as 6 months or as long as indefinitely, I think that that's an appropriate use of a retrievable IVC filter.
Patty? I
Dr.
just have a
Rossi.
comment from Brazil that we were watching the increase of IVC filters, implants there too. So the hospitals, they began to put this document on the patient's files and the documents is like this. On the first part, you have the indications from chest. So you have to mark the doctor there that is going to do the procedure has to mark the indication for an IVC filter. And then on the lower part of this document, he has to justify by himself the indication about in that particular patient. And then this document goes to the patient's files and comes back 2 months later. And on the other side, you have this device was retrieved on that date, or if it doesn't, they call the doctor and they ask him to justify why he didn't retrieve the IVC filter. So doing that, we have been watching a decrease in IVC filter implants there. So maybe a lot of indications weren't good enough or justified, see? So the costs have been cut because we are watching what they say is justified to implant these filters.
Well, it also depends on, a lot of us are technicians, and sometimes we leave the long-term management to the primary care physicians, but following up these patients is a big deal. An IVC filter implantation, I hate to put it so crassly, but it's a fairly straightforward and simple procedure in most patients without variations of anatomy and a lot of thrombus in the iliac veins and the IVC. But long-term follow-up of these patients is very important. It's an incumbent upon the operator that places the IVC filter, if not to personally follow up these patients, but have a mechanism in place for follow-up of these patients. And I believe too often the IVC filter is placed and then and the follow-up logistics are not enforced.
Any other comments? Well, it's a pleasure to ask Dr. Hunter to come back up here to talk about his experience with filter removals and managing obstruction. Well, you're going to give that case that's interesting about the filter removal and then talk about temporary filters, right? Thank you.
I always learn so much when I listen to Tom Rook talk, because there's advantages to practicing evidence-based medicine, but the big disadvantage of evidence-based medicine and relying on studies is the fact that you begin to think and act algorithmically instead of applying some degree of common sense and individualization of patient care. And Tom's method of approaching this has always impressed me, and I once again thank him for that. I knew from the talk that was coming before me that I should keep this simple, and also, because there would be enough data there for us, practical and oriented towards consideration of individual patient scenarios. So the title was Temporary IVC Filters, Yes or No? And the answer is yes. And then there's only the problem of questions. And actually, based on what you have available to you in terms of permanent or removable or temporary, whatever you want to call them, IVC filters, I think that there can be some questions. For instance, the first question should be, well, if temporary filters can be, because they are allowed to be in almost all cases that I'm aware of, permanent filters, why not just stick them in? If there's an indication for filtering, and if you can take it out, fine. If you can't, leave it in. And the only problem with that is that, as Haralder was pointing out in his talk, almost every one of the temporary filters has had or continues to have certain mechanical and functional problems that I think are relatively significant. And they have been bothersome enough so that we have taken out a few filters that were stuck into things like the duodenum. I took out a filter about 3 months ago that was stuck into an aortic aneurysm, which was a fun exercise. And there's enough problems with them, with that fracturing moving around, and that these problems seem to increase with time, so that if you've got a better filter that you think you have on hand as a permanent filter, I'd say maybe in some cases, if you're not sure about when you might want to remove a filter, that maybe the answer is no. And another question, how about if the patient's an older patient, has cancer, is not expected to live more than 12 months? Well, do you want to subject them potentially to filter removal and another $8,000 or $9,000 bill, whatever it happens to be in your hospital? Or if their mortality is relatively assured in the next 12 months, and you have a good enough permanent filter that you think is not going to cause them any particular problems, I'd say maybe the answer is no. And actually, in the last maybe a year, I've put in 2 permanent filters for this exact reason. Another question, variation on the first. What if they're older, they have cancer, but they're able to be anticoagulated? Well, actually, if you have a true indication for a filter, and remember, the ability to anticoagulate a patient may be a reason specifically not to use a filter in the first place. But if they can't be anticoagulated in the short term, and we've seen that it does short term reduce the incidence of pulmonary embolism, how about still, even if they can be anticoagulated later, putting in a permanent filter if you have one that you like? And I think, once again, the answer is totally acceptable, totally reasonable, saves cost, and if they can be anticoagulated, you also decrease this risk of potential DVT in the future. And this risk of DVT, by the way, in the PREPIC study, as you pointed out, and I took a careful look at this study as well, they never, ever specified in this whether or not these episodes of DVT that were continuing to rise were in the group who were not taking anticoagulation, which is a serious weakness of that study. And I thought of another question, actually, related to one of the points that was brought up. If you don't have a person or a plan in place, either enforced because, as they are doing in Brazil, the hospital forces it on you, or you are choosing to have somebody dedicated to following up patients, to making sure that they come back if they are supposed to come back, when they are supposed to come back for consideration for filter removal, and if they don't, that you know about it and you're tracking them, then I would say that, you know, with the increased risks that you have with some of these filters, if you leave them in as permanent filters, if you, by the way, Google IVC filters, the first 2 hits on the top are lawyer hits. If you've been injured by an IVC filter, call here. That's always scared me about this, and I think that a lot of it has to do with this. So unless you like showing up in court, I wouldn't put a filter in maybe in the first place. And then there's the final one, and that is related to people that sort of put filters in as a sideline to their other practice and don't have adequate skills to manage some of the more difficult and trickier removals. And if your technical success rate is 90% or less, and if you look back at your data and you're not taking out more than 15%, by the way, which is the 30 to 50% was the top the average was actually below that in the United States and still is. I think it's time for you to completely reevaluate whether or not you put in filters at all, and so the answer is still no. And then there's one particular filter that has some good scientific evidence, but in our case it was purely anecdotal evidence that I think you very much have to be careful of putting in as a temporary filter, and that's the Optees. You have to be sure, and I'm going to talk about this in the next talk, it will not be in longer than 3 weeks, period, end of story. Unless it happens to be smaller than the cava you're putting it into, in which case it doesn't matter. Or if you think you might be leaving it in for longer than 3 weeks, it's obligatory to get a CT ahead of time to make sure that you can actually remove it. And this patient, unequivocally, of all the patients in whom you have filters, and by the way, if I had a filter in me, I would want to be on permanent anticoagulation, simply not only for the reasons that have been shown, but the original data from the Mayo Clinic, which is the only place in the world I know that could collect data over 40 years or whatever it was, showed that after 20 years, about a third of people's cavas with chronic filters in them of the original Greenfield type were actually completely occluded. Most of them, interestingly, as Tom Rook pointed out earlier today, silently, without any symptoms whatsoever. And if you're thinking about doing that Optees filter and you don't have those conditions fulfilled, I'd say no. Should he ever put in a permanent filter? Well, the permanent filter that I like pictured in the bottom right almost never, ever moves, always centered, always stays in the position that you put it, never tilts, and in addition has the standard Greenfield flow patterns when it's tested with in vitro flow models that suggest that it will have minimal flow disturbances. Unlike the Optees, and the other problem we'll look at with that in the next talk is that flow disturbances are pretty significant. And I think if you have a permanent filter, then for all these reasons, if you have cases that I specified, I think a permanent filter is completely legitimate, and I like this one. Easy to put in, easy to use. So in summary, the answer to the first question is maybe, and thanks again. All right, and then we're going to move right on to a difficult filter removal. And this was an Optees filter, and I'll show you how I struggled with it and ultimately completely and unequivocally failed. The patient, as the slides come up, was a patient who was seen at our local county hospital with polytrauma and was an extremely ill patient with significant both body and brain injury. And he had a prophylactic Optees filter placed, and they were hoping that they would get it out of him within about 3 weeks, and they were actually close to correct. The mistakes that I made, by the way, in trying to take this out, I know that everyone is supposed to have M&M conferences, and pretty soon if you don't, it's another reason you won't get paid. But in our M&M conferences, I've always tried to use a scheme of analyzing complications that make sense to me. And this is the scheme I put together for our M&M conferences that I've tried to enforce over the years, but now that I'm no longer the director of IR, it's sort of fallen by the wayside, but every time I'm there, I keep asking the same questions. Is it an error in judgment? And almost always when you have a bad complication, it's one error in judgment that then led to several other errors in judgment as you tried to sort of balance and compensate. Or is it a pure mistake? You just plain did something wrong. Or is it your inability to recognize or predict a problem or an abnormality? Or were you doing something that was just idiotic? You were hurrying, you weren't paying attention. I biopsied the wrong level in a lumbar spine one time that led to weeks and weeks of paperwork and hearings, and it only went away when it turned out that the level that I biopsied was also positive and became important information. And I was hurrying, you know, and I just didn't count correctly. It was a bad Saturday kind of thing. Or is there technological inadequacy? My first superior vena cava stent was done with the only Z stents that were available at the time, all of which were short. 3 or 4 of them popped out of the stenosis one way or another. And in trying to relocate them, I got a sudden superior vena cava occlusion. The patient went from a stenosis to an occlusion, sudden increase in intracranial pressure, and died. Boom. And that was clearly our complication, but it was one that was based on the technological inadequacies of the time. Or is there a system problem? And a lot of people lay these things off on system problems, but this one was an error in judgment and an inability on my part to recognize, and I'll tell you why soon. So, sick kid, filter placed June 20th, a couple of years ago. And the first attempt to remove it was actually about 4 weeks, which isn't bad given the severity of his injuries. They failed because they couldn't engage the hook on the bottom of the Optese filter. So they sent the consult to me, can you take this out? And I said, well, I can certainly try. And so we got him over a month later. We are now there for about 2.5 months after placement. As you can see, they analyzed coming in from the groin where the renal vein was, tried to put it fairly close to it. During the course of the next 2.5 months before it comes to me, it gets down to just about 1.5 centimeters above the iliac bifurcation. When they first went to get it out, it didn't look too bad, and there was good flow through it, but they were unable to engage that hook, and afterwards they had a lot of wall edema from trying, and you can see how sort of narrowed and irregular that wall looks, but they anticoagulated the kid. He did okay for a while till he came to us. So by the time he came to us in my retrieval attempt, his filter still looked in position, a tiny bit more tilted, but now actually migrated south almost 2 centimeters. So it's just above the bifurcation, and the tilt of the filter is actually maybe a little bit more, so that hook is probably sticking in the wall even further than it was before. But the other thing I'd like to point out to you is it looks like the legs of that filter, the vertical legs, the struts of that filter are actually outside the vena cava wall, lumen, and by God, they were. In round number 1, we came in, this was all done the same day. We came in, tried to get through and through access. We were able to get through the bottom of the filter. Manipulations causing a little bit of narrowing of the cava at that point, as you can already see, but we were unable to really snare that thing, and we got a kink in the wire, and so we actually had a great deal of difficulty removing the wire. We reassessed with flow, decided that the flow was adequate still through the filter, decided to go through round 2. Round 2, we were able to actually get a wire up and around, grab a hold of it, but it kept slipping out of our grasp, and we really couldn't grab a good hold of it. And so we tried to put it through more of the struts, and by now, by forcing ourselves through the edge of this thing, we're starting to get some significant distortion of the filter. And then, as you can see, the wire kinked. We couldn't get rid of that kink. So eventually we had to put up a long sheath and actually straighten out that kink inside the sheath, and we were done with attempt number 2. Round 3, I said, well, let's try and grab it from the opposite side to remove this kinking problem, make sure we use a glide wire, which had failed on the first attempt. And then if we can get it from the opposite side, which we were able to do, then we'll grab it through a snare from the ipsilateral side out of our own snare on this side, and we'll be able to pull it down. We were successful in doing that. We grabbed a hold of it, started to pull it down. We were actually able to get our new big sheath over the top of that thing, and we were actually able to start to move that filter hook out of the wall and to pull on that filter to get it down further. And I said, finally, after 3 hours of work, I think I'm going to finally get this thing. And we got it about that far in, and it would not come further. And I yanked and I pulled, and it would not come further. And I put as much stress on it as I possibly could, and then I did a venogram. And you can see that what has happened is that that cava is completely downward collapsed into the filter and into the where the filter is actually pulling the cava itself down into the sheath instead of actually collapsing into the sheath. And so I decided that this was bad enough that I would let this go. And as I tried to pull everything out, I realized that I had the one leg that I'd really had a good hold of still in my grasp. And so we actually got one leg of the filter removed on this particular day. I anticoagulated the kid as well as I could. He developed HIT before this, so he was placed on fondaparinux. And we got him anticoagulated, and he chose not to have any further attempts. Interestingly, a follow-up at his local hospital a few days later showed that the filter was still visible on ultrasound, but there was absolutely no flow through it. So by damaging his cava to this extent, I had caused complete occlusion of his cava. But interestingly, because of all the stuff he had done, you'll notice a little bit of color at the top. He was already developing collaterals. And as Tom said in his talk, occlusion doesn't always equal swelling. And even though the filter was there and there was no flow coming out of the iliac veins through the filter, it was starting to go around it already. And the kid never developed any swelling of either lower extremity. A quick look at the optes that has little hooks that prevent it from migrating up. Nothing that prevents it from migrating down. The hook at the bottom is shaped so that it's very difficult to see on a CT, so sometimes you can't tell if you're dealing with an optes or a trapeze. If you grab that hook in time, the filter should collapse relatively straightforwardly because of the double geometry of it. But because of the fact that you're squeezing it from below and collapsing the filter into any clots that are in it, they squish out of the filter instead of actually coming down with the filter. And any clots that have trapped on the bottom side, and this is the big problem with this filter, and the reason we decided not to use the trapeze or the optes, because of the fact that clots trap on the bottom outside. And as Harold there said about our own original efforts to produce a retrievable filter, the Amplats, when you trap clots to the outside, you very rapidly reduce the flow area, whereas if you trap them in a cone in the center, the flow area around the outside stays very large until you have a huge clot burden. So with a much smaller clot burden, about 1/4 the clot burden trapped in the outside of a clot like the trapeze or the Amplats, you will reduce flow to almost no flow, which is one of the reasons I think we had such profound problems with thrombosis of this filter and eventually didn't use it. In addition, even if you take a look at ones that were successfully removed in animals, there's a couple good animal study, you notice that you do a lot of damage to the wall and are left with narrowing of the caval lumen. You can see the amount of damage on the slide on the right that actually occurs even when these are removed successfully in the appropriate time interval. Most importantly, and the reason I did not know this, which is unacceptable really, and that's why I say it's an error on my part, is that all of the literature on this filter is in the trauma ortho literature. There is none in the radiology literature, absolutely zero. And I had never seen these articles until I started looking up my complication. Their retrieval rate in animals after 30 days was 0. So if you're not within that 3-week time period, you're not going to get it. And the reason is right there. If you look at the right-hand slide, you realize that even at 3 weeks, the legs on that filter, which are vertical, have enough compression on the wall so that they go right through the wall. And in all the animal experiments that were left in for 2 months, all 6 legs were completely outside the wall of the inferior vena cava. And that's why this filter absolutely will not come out any longer, usually than 3 or 4 weeks. What did I learn? HIT can be treated with anticoagulation, and a filter is not always needed at all, which speaks to the same points other people were making. If you're going to use the optes or the Venatech, which have side legs, you want to kind of cheat the filter up towards the renal veins because it's almost impossible to occlude them, and if they're closer to the renal veins, they will obviously leave you with much less chance to get clot above your filter, and every filter-associated significant pulmonary embolus has clot above the filter. It doesn't come from any other source. And one of the big complaints that I have about all these studies that show pulmonary emboli with filters do not address either the technical problems of putting the filter too low and therefore allowing clots to accumulate in a filter and then propagate through it above it until they reach the level of the inflow of the renal veins and then get blasted off as pulmonary emboli, which I think is a critical issue. And one of the things that I've hammered fellows and residents about for years is that you have to get it close to the renal veins, otherwise it's not in the correct place. clearly can't exceed the FDA limit of 3 weeks on these filters, and you can't force them out. If they're not coming out, you don't pull them out. And therefore, this was a patient who was referred to us 1 week ago at the VA hospital in Minneapolis for removal of a filter. They said it's an Optese filter. It's difficult to see the hook. You can kind of see it in the bottom left picture. But when we took a CT first to see what was happening, you'll know that notice that this filter had been in about 4 months. The hook on the bottom right is completely outside the wall of the inferior vena cava, and on the CT in the middle part of the filter, every one of those struts is either in or completely through the wall of the inferior vena cava. We said, no thank you, patient needs to be on lifelong anticoagulation. Don't stop their anticoagulation, which is what they were going to do as soon as we got the filter out, and they were going to do anyhow, even if we didn't take it out, and we said, no, can't be done. And even filters that are good ones that I like a lot, like the new Gunther Tulip, can have troubles. And the reason is because of the fact that they have these little side wings that are actually straight bars that impact the wall of the inferior vena cava. And anytime you have something straight, like the trapeze or Optese filter against the wall, it will start to incorporate that entire piece of metal into the wall as it exerts pressure. It can't do anything else. And take a look at this. This had not been in that long. It was only about 2.5 months or so, and I was taking this out, and I got down to this point right here, and it would not go further. And if you take a look at the inferior vena cavagram that I did at that moment to see what the hell was happening, you realize that those side wings had grown into the wall enough so that every one of them is still in the wall and it's still pulling that cava together. Look at that cava, it's exactly the same size as my sheath because the wall is being scrunched in together. So anytime you have straight vertical components to a filter instead of pure conical components, you run the risk of actually having them go through the wall and making filter retrieval extremely difficult. With a good yank, I got it out. But look at what was happening to the bottom of my sheath in order to do that. You can see that I was pulling cable wall and filter in together, and the bottom of my sheath looks like a top hat, where the walls were not strong enough to resist that force. And if you look carefully at the cavagram, thank God there's no leak. You know, if you'd done this, taken this out with a laser, I bet you would have had a big leak there. There's no leak, but if you look very carefully at it, you see that there's wall irregularity, those little jagged irregularities where things were clearly torn out of the filter, and I'm sure if you threw an IVC in there, it'd be a little bit scary. So, the end of this talk, like the previous talk, is the fact that in addition to the great science that has been done and that needs to be done, I think every one of us, every time we do any procedure, in addition to thinking algorithmically and on the basis of evidence-based practice, needs to have a certain amount of artist in us in order to get out of these things without seriously hurting patients. Thank you.
Thank you very much, David. Did anybody have a question for Dr. Hunter? Yes, please.
When you take the filter out and the cable looks jagged and ragged like that, do you put them on a platelet inhibitor?
You know, that's a good question. And in general, almost all venous problems, and DVT in particular, have never been shown to be significantly responsive to or dependent upon platelet inhibition, much more on anticoagulation. So when I saw this, I mandated a week's worth of anticoagulation because healing times in blood vessels, if they are otherwise normal, as the surgeons will tell us, is relatively complete in terms of forming all the little intracellular bridges and whatnot that reestablish continuity of vessels and reestablish some degree of functional regularity in about 10 days to 3 weeks. So I mandated a week's worth of anticoagulation on this patient.
Thank you. Any other questions? Okay, good. Well, now Dr. Ossie is going to talk about trying to deal with an endovascular approach to obstructed inferior vena cavas and cavas within which there are obstructed filters. Dr. Ossie?
Well, thank you again for this invitation to be here in Chicago to present our data. And differently from yesterday when I presented you with a nice picture of one of our patients, this is the other side of the same coin, where we treat patients with inferior vena cava occlusions. And this is how we see them, how they present in our office and their clinical presentations, where you can see that these are special patients with low quality of life. And, well, some of them come to our offices saying that they went to a different number of physicians and they all said that there's nothing to be done and this is what they get, and they'll have to live with those legs and this kind of presentations for the rest of their lives with stockings and anticoagulation. So I don't think this is fair for these patients to do that, and this is why we decided long ago to change that and to try to help them to have a better life. In the last years, we have seen a lot of patients being diagnosed and treated for May-Turner syndrome. And we know that May-Turner can be one of the sources, one of the causes for inferior vena cava obstructions. So these are the patients that have been pulled out of this risk group. So why don't we treat the other ones, the ones that already have an occluded vena cava? So this is what we did in the last 15 years, from 1996 to 2011. We have treated 324 patients for DVT, and 48 of them were patients with an occluded inferior vena cava, so it's 15%. And if you see that, they're all male, young patients. So these are the guys that have a family, they have a job, they have a life ahead, so why don't we treat them? This is something that I keep asking in every meeting that I go. So if we have the tools, if we have the techniques, if we have the methods for endovascular reconstruction of aorta, why don't we use all of that to treat those patients? If you see that, most of our patients are chronic occluded cavas because they come after they went to different doctors, and so we have patients with a range of 7 years of symptoms and signs of occluded inferior vena cava and post-thrombotic syndrome. I want you to pay attention to this, and I think Dr. Thorpe will talk about that later, that these patients with severe post-thrombotic syndrome, most of them are patients with blood type A positive, and I'll show you a picture of our latest patients to prove that. And we, Dr. Thorpe and I, we strongly believe that there is something with this blood type that drives those patients for a more severe post-thrombotic syndrome, and these are the ones that we must treat more aggressively. I want this. So from these patients, almost 40% of them had a history of pulmonary embolism. And as we expected, almost 40% of them had a diagnosed May-Turner syndrome. Malignancy was present in 10%, so they are not a regular customer with presenting with occluded inferior vena cava. And we also had something that's related to this afternoon presentations, that 7 of them, or 15%, had an occluded inferior vena cava due to a presence of a filter in their vessel. So this is what I wanted to present, to show you These are the last patients that we treated with an occluded inferior vena cava. And if you pay attention to their blood type, there's something very interesting here. Most of them are A-positive patients that we just decided to study that, and the new ones that are coming, they are still doing this. All of them, or most of them, are A-positive patients. We decided to divide the inferior vena cava in segments so we could see what kind of patients we were treating. So a total occlusion was present in only 18%, or 3% of all cases that we treated. Suprarenal is very rare, and it's due to the renal flow that, kind of protect that segment from occlusion. Infrarenal was present in 15% of our patients, and the most prevalent cases were the ones that had an iliac vein included in their occlusions. And we decided to go and see what happened here. And we expected to have a lot of unilateral patients, especially on the left side. But what we found out is that most of the cases were bilateral, and we don't know if they used to be unilateral at the onset of occlusion and then they turned it into bilateral, or they were bilateral at the beginning. The other thing is the unilateral presence occlusions had a slight more incidence of left side. We expected more than that, but this is how it was. Okay. And all of these patients were presenting severe post-thrombotic signs and symptoms. So these are special patients that will have a worse quality of life in the future if we don't do anything for them. So this is what we did. Flow-directed lysis in 75% of all cases, catheter-directed lysis in 100%, because these are very special patients with long segments occluded. So we must do this in order to have a track to find a way to cross the lesion and do plasty and recanalize those inferior vena cavas. Because AngioJet was available in my hospital only 3 years ago till now, we did only 9 cases of that, but I do believe that combining lysis and AngioJet makes it easier for you to cross the lesions and use a lot less of TPA and heparin with those cases, with those patients that raise the risks for complications. Access. We had jugular, femoral, and popliteal access, which were the most used ones. Jugular access were more used in combination with popliteal to come from the upper side and the lower side to cross a more difficult lesion. So our preference is to use the popliteal access. We did use a lot of lytic drugs. We did use a lot of heparin, but again, these are very special patients. They take a lot of time to do that. As you can see here in the number of procedures, some patients we had to go back to the angio seat 10 times until we got a way of crossing the lesion and treating those segments. And also, there is a lot of patients that we had to put more than 3 stents. Okay. This is the kind of reconstruction that we may do. We do prefer the double barrel reconstructions because we believe it's not studied yet, but we believe that if you have a problem, a technical problem in one of the legs, the other one will remain open, so you just have to go to one side to fix a problem. And this is how it looks like after you reconstruct your inferior vena cava from the iliac veins. Okay? This is bilateral axis. As you can see, a swollen leg bilaterally, and bilateral axis from a popliteal axis. This is when we start, and you can see all the collateral veins and an occluded inferior vena cava. But after 24 hours, you already find a track, a way, something that looks like an inferior vena cava. And after 48 hours, you do have all the way up. So you just start to do the angioplasty, what we call kissing plasties, all the way up, down. So on the third day, we implant all the stents in that double barrel, coming all the way from the right atrium to the iliac veins. And this is a patient that it's already 10 years after procedure, and he's doing fine. I just wanted to put this picture to show you, to show you that we are dealing with a very special kind of vessel. So the inferior vena cava is not an artery, so you can see the stents inside the vein and how delicate this structure is. So you must be very careful when you are doing those procedures. Another case, and this case was of a patient that was referred, and she had chronic renal failure and also inferior vena cava obstruction. And the doctor from Rio de Janeiro called me and said, well, we want you to recanalize this inferior vena cava in order to allow us to do a renal transplant. So we treated this patient. Hello? Okay. So we treated the patient. We did recanalize that inferior vena cava all the way. And these are the results. And she called me yesterday saying that they are planning for a renal transplant next week. So I think it was a good result. This is how the double barrel looks like in a CT. And this is one patient with an occluded inferior vena cava due to a presence of a filter. So we had to cross the filter and exclude the filter from the circulation, but the cava flow was restored. So results: we had 5 deaths after our procedures, but none of them were related directly to the procedure, but the underlying diseases. The mean follow-up is almost 6 years, and primary patency were close to 70%. We had additional procedures, or we had to redo something in 13 patients, but interesting is that only 2 of them had an occluded segment after recanalization. Most of them had only stenosis that we treated with plasty, and they did well after that. So we have a secondary patency rate of 98%. And one of the patients that we didn't do anything, I want to show you, if I can. Which one? Oh, this one. Yeah. Okay. Is this. We started to do the lysis, and what we found is a tumor, a cava tumor. And so we decided to stop everything, and that's why we have just one patient that we didn't implant a stent or didn't anything, because we found this after 24 hours of lytic therapy, and so we stopped everything and referred the patient to an oncologist. Complications. So we had minor complications. Again, these are very special patients. These are very special procedures. Takes time. Your energy goes down with those patients, but you have a lot of gain and pleasure giving them back their lives. So minor complications. Access site bleeding, it's normal with this kind of procedure. Back pain due to the stent implants. We had during the procedure, only 3 occlusions of what we are doing, that the lytic therapy just got rid of everything, and we started again. Major complications. We have 1 muscular bleeding, 1 intracranial bleeding, and this was another patient that had chronic renal failure, and we think that at that time we used more of a lytic drug doses than we should, and we learned with that. We had a caval rupture that we treated with a covered stent, and the patients as well. No deaths. So in conclusion, we do believe that inferior vena cava endovascular reconstruction can be done, and it will help these patients. And they do have a long-term result that is equal to any other venous procedure that you usually do. And for these patients, the post-thrombotic syndrome that will improve, will give them back a better quality of life. Thank you.
Stay right here. Are there any questions? I want to make just a comment. These are the most difficult endovascular reconstructions we do. They are very time-consuming, but again, it is extremely rewarding to be able to help these patients. Dr. Rossi did show that one picture of a cava from one of the animals that we were working on, I believe, and it does show that the cava looks transparent, but when the cava is chronically occluded, it retracts, and we see on IVIS now that it's very dense material. There's nothing left of the wall in most cases. You can see it all because you can track it to the level of the renals in a lot of these occluded cases. And as soon as you get into the normal appearing cava, it does then resume that very retractile, thin, flexible wall. But where it's occluded chronically for several years, it becomes very dense fibrotic material. So that when we do the kissing balloon augmentations from 6 to 8 to 12 with 2 balloons, we've never had any problems like that. I think you only have problems of injuring the vessel wall when the cava is actually acutely thrombosed or more of a normal wall. Would you agree? So a lot of people always ask me how you can do these things. Aren't you afraid it's going to tear? But you can perforate it with a wire, but it's so fibrotic and there's no flow there anyway when you're working your way through that it's usually not a risk of a hematoma. Yes?
How did they transplant a kidney? Did they have to go?
I think they haven't done it yet, have they?
No, they're doing this week. Well, they asked me to leave the iliac vein free of stents or everything, but they also said, well, if you have to put a stent there, once we get there surgically, we'll just open that and make sure that the vein will have somewhere for us to do the anastomosis.
Interestingly, people ask the question about crossing the renal veins with stents. We exclusively use wall stents for these reconstructions, but there's never been any problem with flow from the renal veins into the stents. You may cross the orifice, but it doesn't obstruct the flow, just as it does not obstruct the flow to the hypogastric or internal iliac or the lumbar veins either. Any other questions? All right, I'm going to show one short case before the break, and then we do have some time for more questions if necessary, but you want to put up this. This is a case of a duplicated cava. Let's see, we have the clickers. Why don't we show of all, let's do it with A, you've seen a case of a duplicated cava during your career, and B, you've never seen a case of a duplicated cava. Let's see what we come up with in terms of who's here. I haven't seen too many, but so they come in clusters like other lesions. Have you done it? Is it calculating? There. So let's see, three people in the audience. Well, here it is more. Oh, let's see. Well, not everybody's answering or if you've never seen. So most people have not seen one. What is that one that keeps moving? A new category. It's, you know, it's like May Thurner. Before we knew about May Thurner, we didn't know that we weren't seeing it. Do you know that 1 out of 500 live births has a duplicated cava? So I want to present this case to you because if you have a patient in whom you have multiple PEs and you don't know where they're coming from and you can't diagnose it, and they, well, he keeps having PEs, but I've never heard of where they're coming from. Think of this patient, remember this case, okay? This is a very interesting man. He actually was an Army sniper over in the Middle East. This is anecdotal, but it's in the afternoon. Do you know the Army snipers? I thought, well, they're up in the church or the tower or some building up high. He says, no, in the Middle East, they're buried in the sand with camouflage over them. Just keep thinking of that. So he's a 51-year-old man. He has 7 kids. He's retired from the Army. And he visited our hospital for syncope. He had a negative head CT. His INR had been followed at the VA hospital, and he was actually quite anticoagulated, so he was transfused and given some vitamin K. INR went down, started on Lovenox, and that was kind of the acute history. And then he came back and presented with chest pain, was treated at another hospital, and he actually had some stenoses in his coronary arteries, so some stents were placed. And there was a question then of whether or not there was a PE, but there was never any good documentation. It started on warfarin. And here's just a picture to show that, indicate where these stents are. You can see, I think, right there, some coronary stents. Well, that turns out to be somewhat incidental here, but then he was in our hospital when he started to have some more chest pain. And when you go back to his history, it was interesting. He had had a pulmonary embolism in 2008 and a DVT of the right leg. When he was, stuck on Army reconnaissance planes for a long time, he was immobilized in the plane. He did have an episode where his right leg swelled up quite a bit when he was in the field in Grenada. And his initial diagnosis, he thought, was some kind of insect bite. But then he was diagnosed with DVT, and he was put on warfarin only for 6 months. But then if you go back farther in his history, in 2006, when he was in Panama, he might have had something. In 2003, he was in Iraq. He thought he might have had something. And when he was in 1990, he was in the Gulf War, he was shot in the abdomen, and he had had a surgical procedure. And from that, he had had a lot of post-traumatic stress syndrome, which was all part of his history. But then if you go back even farther in his history, when he was 29, he presented at a VA hospital as a young recruit with a history of, quote, asthma and chest pain. Well, looking back in retrospect and seeing this history, it's quite possible that that was his first PE. So I don't think that this is pertinent, but it's interesting. He came from a multicultural family, and it was a very educated man. He was a very interesting man. He was on a long list of medications by the time I met him for depression and for hypertension and hyperlipidemia, etc. Well, he had some studies that were negative. His cardiac echo was normal. His lower extremity duplex was negative for DVT. His hypercoagulability workup was negative. He had no physical signs of venous insufficiency. His legs looked pretty good. And he was on inhalers for asthma. Many times I've treated patients for chronic lower extremity DVT, and they all say they have asthma. But they haven't had any real workups for asthma. It's just that people put them on inhalers when they say, well, I'm short of breath. Yes, I'm short of breath. Okay, well, we'll put you on these inhalers. And it turns out that when they come back in follow-up after we treat them with lytic therapy and fix their legs, they say, you know, doc, the best thing about this whole thing is that I'm not short of breath anymore. And we know, you don't cure asthma with lytic therapy, but you can impact pulmonary hypertension with lytic therapy if it's based on some kind of chronic thrombotic issue. So he had a CT, and the only thing that was shown was an asymmetry of the testicular area, but the large vascular structure on the left tracked to the iliac vein. Well, that was read as a large testicular vein by CT. So we went in, and I said, you know, I think you deserve a venogram. Because you keep having multiple PEs, maybe we just better put a filter in to stop that. Because no one had ever put a filter in all these years. So this was the initial venogram. And here was another image of the venogram. I don't see too much like anything. We're coming from the right side. So we put a filter in. And then I came from the left side just to see what was going on. And there we saw a duplicated filter, a duplicated IVC. And not only that, it looked like we wondered whether or not he had a May Thurner. Now, I've seen cases with duplicated IVCs that do have a May Thurner. In this case, what I want to share with you is the quality of flow in the duplicated IVC. You can see the catheter coming from the other side. Let's see if this is the IVUS that shows the May Thurner area. This is the filter that got placed in the regular cava, what I call the regular cava, the primary cava. And this is the secondary cava or duplicated cava. Because on the first day we just put in the filter, and then I thought about this a lot and thought, well, clearly it wasn't a testicular vein, it was a large duplicated cava. We'll see if this the video plays. Here we go. Now, look at the way the flow is. I think there are two videos. This is the one video I have. The flow through the duplicated cava actually comes up and hits the flow coming from the renal vein. Can you play that one more time, please? And what happens is that there's flow pressure from the renal vein pushing flow backwards. So you actually get retrograde flow in your duplicated cava. It goes up and then backwards, up and down. So it's sort of a sump effect in that duplicated segment. And so then I came to understand how you could have these situations where there is a sump effect where stagnant flow under certain circumstances, immobilization, could even cause more of an incident of pulmonary emboli forming in that particular segment of the cava, or that duplicated segment. So the treatment options the treatment options do include putting in a second cava filter. And we just heard this talk from Dr. Hunter, and I don't like Optese filters either, but we didn't have any other choice that day. So in that case, we did put two different kinds of filters in. And here's some information about the incidence of duplicated cavas. It's about 1 in 500 births, or incidence of 0.3 to 3%, varies in the literature. It's a congenital abnormality, and it can complicate aortic aneurysm surgery, but it is a common cause of recurrent PE. And CT is the best diagnostic tool. There are very few reported series of any size, but other abnormalities are identified too with retrocaval ureters, etc. But the indications in the literature for IVC filter have already been reviewed here today, but it's true that the embolization can come from the unprotected duplicated cava. So it can be ligated, it can be embolized, or you can put a filter, a super filter there, or you could put a suprarenal. Well, we don't like to put suprarenal filters. I think it's more benign to put in two filters. I think putting in a second filter, it could be debated, but I think it's better than embolizing that vessel. This is a paper that came in vascular and endovascular surgery in 2011 that talked about different options and what had been done in a series of patients, which is fairly large. Greenfield reported 71 cases in 1992 where they put filters in. Bilateral filters are relatively uncommon, but I don't think we're seeing a lot of these duplicated cavas. Perhaps we're only looking for them in patients that are symptomatic like this, and they're probably more common than we know. We don't see them. Complications of the filters, we've already reviewed that today, I think, sufficiently. So this article caught my eye, though, because it says that studies on the characteristics of venous blood flow and endothelial function of duplicated cavas are lacking. And when I've ever showed this case to everyone, I don't think, and I myself, it was many years doing interventional radiology, that I had never seen a case where I was able to document the retrograde flow in the duplicated cava, and that's very unexpected and actually makes sense once you figure out the hemodynamics, but it also explains why they can have multiple PEs. So recurrent PE without a source, think of a duplicated cava and then see if it's something that you can treat effectively. So any questions? Dr. Hunter, I've had a lot of experience. How have you treated duplicated cavas that were symptomatic?
Well, I've never had a duplicated cava that was a source of multiple PEs, but I would be very worried about that filter position because if the retrograde flow in the cava is part of the reason that you're getting the DVTs, putting a foreign body in that area is just going to increase it. And particularly with that filter morphology, any clot in that filter is going to go to both sides of it, filling that thing up, and you might get even worse PEs. I would have thought, in this kind of a case, if you're worried about retrograde flow being the cause of it, I think that like putting an amplatzer at both ends of it and just letting the whole thing clot off is probably the best option. You get great flow across the iliac vein to the right side, which isn't always there when you have duplicated cava. Sometimes you have no communication. The other thing, as you know and I know from all these cases that we've done, I've rarely seen a patient who has only one reason for getting DVT. Almost always there's 2 or 3 or 4 things happening in conjunction, like all the birth control people who also have factor V lag disorder and that kind of thing. My guess is that duplicated cava is fairly common, and then you put together that with some kind of thrombophilia that we aren't able to diagnose yet, and there's got to be some of them because we keep coming up with new ones just about every other year. My guess is the person has some kind of thrombophilia in addition that just doesn't fit into the panel of tests that we currently do. I think I would treat a patient like that with chronic anticoagulation until proven otherwise, particularly if you're going to stick a foreign body in that cava, and that cava is going to actually be the source of the emboli.
And the position of that filter, in retrospect, should have been closer to the renal, I'm sure, if it was properly placed. But your point's well taken. Although I think that it could, just the way that flow is, could be a source of intermittent emboli in this patient without thrombophilia, because he had no evidence of thrombus formation or anything that we could detect in the legs or any chronic changes. It would be unusual for, well, thrombus can form anywhere and embolize without evidence, but I thought the to and fro flow was significant. It's never been described in the literature, and it makes sense with the competition from the renal vein. I've seen the other couple of cases I've seen where there's an insertion actually into the cava, not into the renal vein, so it can have a variation of anatomy. Okay, well, we'll have to follow up on him. He is on anticoagulation, so we'll see how he's doing. If there aren't, let's see, it's 3:30, and the Refreshments begin at 4:45. Are there any other questions? What we could do is we could break early and have a little bit longer break, or we could go on with another talk right at this point and stay on time, because we do have Dr. Grady added on in the afternoon. Anybody should we do one more talk? Or would you like a break? Come on, we're a small group. What do you think? Okay, would you like to do? Okay. You could put up the predicting post-thrombotic syndrome talk, and we can do that now. And then we'll start our afternoon with Dr. Ossie's technical talk about calf vein DVT. This is the talk about, Dr. Ossie alluded to this, because we've done a lot of work together. I started this work in the early 1990s when we started seeing young women come into the hospital with DVT. And I had known from the 60s, late 60s and 70s, that the birth control studies that showed whether or not you got more thromboembolism with birth control pills showed clearly that non-O blood was the least kind of blood type to get thromboembolism, and that A and B blood had much more chance of having thromboembolism, or PE, associated with hormone therapy. So I had always kept in my mind that there could be some connection between DVT and blood clots and blood type. So when it comes to predicting and preventing post-thrombotic syndrome, we don't really have a way to profile these patients very clearly. They get DVT. Most of them are lost to follow-up in our system because the medical system is fairly fragmented now, and you don't have the old-fashioned doctors that follow a patient for a lifetime. They come in to see someone in the clinic, the ER. They never see the same doctor twice. So a lot of doctors who put patients on Lovenox have no idea that the patient really doesn't do very well, because they're just out of their clinic and out of their mind, and they don't see the sequences. The post-thrombotic syndrome has been discussed somewhat today. It can be up to 50% within 2 years. We've seen post-thrombotic syndrome develop, and within 6 months, patients who just fail to respond to heparin and anticoagulation, and they're told many times that their leg will get better, just be patient, just wait. And they wait, like the physician said, and it just doesn't change. It stays swollen from the day they get their DVT. The strategies to prevent PTS are kind of of pivotal importance, except for the fact that we don't have very good markers to say who's likely to get DVT. Dr. Strandis, who was talked about earlier in the day, said that multisegmental DVT will result in abnormal leg in almost 70% of the time if you just consider the amount of reflux that occurs, even if the thrombus is autolysed. I think the big issue is that autolysis is totally not well understood and not predictable as well. Well, when you're in the battlefield, they have that platinum 5 minutes to get people to triage and to save their lives. And in stroke, they talk about this golden hour. But in DVT, I've found that this idea of 10 days, and after 10 days you can't treat the clot, is to put it in Dr. Rook's terminology, is a total misconception. You might not be able to pass a glide wire through older thrombus, but that doesn't mean it won't respond to intervention. And autolysis, again, is sort of a mysterious process. And there must be multiple factors, including genetic factors, that determine relative success. Some people seem to get rid of their thrombus, and a lot of the people that we get on the receiving end of being failures of standard coagulation, anticoagulation, like we've shown, end up with a skewed towards non-O blood, which may be just one factor. So the predictors of post-thrombotic syndrome have been sort of focused on the extent of reflux, the presence of persistent popliteal obstruction, the rate of recanalization. Now, it's not only the rate of recanalization, which may not be the issue, it may be the amount or the quantity of recanalization. As we're seeing with IVIS studies, Recanalization can be 10% of a long segment. It can be sort of patchy. It can be recanalized here, totally obstructed here, recanalized on the top, probably related to the neovascularity or the collaterals, channels, the branches that are still open. So recanalization in itself is a term that leaves you not knowing very much. When people are told by their primary care physician, no, don't worry, clots recanalize. Well, the question is, well, what if I recanalize 10%? That's not going to leave me with a very good leg. If I recanalize 90%, that's pretty good. But who's to say that you're going to recanalize all of the segments most of the way? And no one can predict that. And once you don't recanalize completely, you're left with a vein that has a lot of irregular substance on the wall, which after they take you off anticoagulation 6 months later is a nidus for rethrombosis. If you're immobilized, dehydrated, gets, all of the above. And if you have an undiagnosed factor V Leiden, like Dr. Hunter was talking about, well, Prandoni has published a lot about the long-term course of acute DVT, and he's shown that ipsilateral post-thrombotic syndrome is most prevalent and related to recurrent DVT. Now, this is an image that shows the residual thrombus in the middle of a lumen with the IVC in a patient who has a May-Thurner obstruction. And then, of course, I'm showing how we can successfully treat that with endovascular therapy. And the resolution of the thrombus is, like we say, complex. Dr. Wakefield's group in Michigan and other groups have started studying all the other factors. Dr. Hunter just alluded to the fact that we keep coming up with new hypercoagulability issues that are totally below the radar for most people and expensive tests that people aren't getting. But this is a patient from New York who was treated for over a month in Lenox Hill Hospital, didn't get better at all, a very educated professor, and they finally referred him to us at Iowa to be treated, and he did quite well. And there was no indication that he had a hypercoagulability. He just thrombosed small veins. This man had relatively small veins. None of us, if you've never had a venogram or an ultrasound, know what size your veins are. But there's some variability, just like with noses and fingers and veins. Some people have larger veins than other people. He happened to have very small veins that never recanalized, and of course he was A positive as well. So vein wall remodeling after DVT may be similar to wound healing, and it's associated with this increased collagen expression. And Dr. Camarada just recently reported on some good, interesting experimental data that he had where he took some endophlebectomy specimens and analyzed them from patients, actually, where they're doing endophlebectomy, and he showed that most of it is collagen. It doesn't have a large component of anything that's identified as thrombus. This is a 44-year-old man that we treated earlier in the year. For 20 years, he's had a leg that's that large on the right side. His brother also has had a long history of DVT, and he had a cable occlusion as well. But it turns out that he had a variant of fibrinogen that doesn't permit plasminogen to bind. So he was hypercoagulable for an even different reason. And we've been working closely now with his hematologist, going over these data with the blood type information. It's interesting to note that you can't predict post-thrombotic syndrome occurrence with the severity of the initial DVT, with the location of the thrombus, whether or not they get treated right away or not, if they have a family history, or by age or sex, or whether or not they actually have factor V or lupus. None of those actually independently help you predict post-thrombotic syndrome. So I think I alluded to these studies earlier that clued me into the fact that there could be something associated with blood type. If DVT was more prevalent in certain kinds of blood types, does that necessarily translate to not being able to be treated with anticoagulation or recover from DVT? Not necessarily. So is this serendipity, or is this science? We don't know. It requires a lot more looking into, of course. But these are some of the this is some of the information that we do know. We know that O-type people have increased duodenal ulcers. So there are some medical conditions other than DVT associated with blood type. And in the late 60s, this association with hormone therapy was noted. In 71, they saw that non-O blood type had increased incidence of VTE also, and some of these data pertain to cardiovascular events or coronary events. And there's a lower incidence of thrombosis in Asians and a lower percentage, and you know most Asians have O-positive blood. So Mediterranean people and Northern European people have more A. For many years, we've known there's association with blood type and thrombosis from the blood bank people, but it's not widely published and nobody pays much attention to it. So, von Willebrand factors are elevated in non-O blood. Now, von Willebrand factor 8 can be elevated with inflammation and stress, but just as a resting level, it is a risk factor for thrombus. And the mechanism by which the blood group determines elevated factor 8 levels really isn't very well understood. So these recent studies suggest that there may be subtle differences in blood types. It could be antigenic related to the antigens, or things that we're not even testing for, like Dr. Hunter mentioned. So there's features of the ABO blood groups that are interesting. The increased risk attributable to the fact that ABO blood group influences plasma levels of coagulation is pretty strong because of the factor 8. And then when you look at the differences in just these designs of groups, you can see that the antigenicity of the non-O groups is pretty striking. And that's why it's hard to cross-match sometimes these people with all the different antigens. So elevated risk of factor 8, no antigenicity or more antigenicity, and some reported poor clinical outcomes in pediatric patients with elevated factor 8 sort of is one of the dots that we might want to connect in this whole picture. So I'm just going to skip past this. So this study was mostly retrospective because we were looking at all the patients we've treated for the last 20 years, and all of them have undergone the endovascular reconstruction that we're talking about for either acute, subacute, or chronic DVT. So it includes the 324 patients that we saw before in the other study, and in 415 limbs. By far, the majority of these people have more than one segment involved, and most of them are female. Mean age is around 40 years of age, and the mean duration of symptoms when you gather all these people, not just the IVC occlusion patient, is about more than 3 years of chronic DVT. And when you look at the distribution of blood types in the United States and Brazil and globally, you can see that it's pretty evenly distributed between A and O. Now, in each group, in the A and the O groups, somehow it's not reaching here, most of the people are positives. The negatives are relatively small groups in each of these groups. But you see a pretty even distribution globally of the A and the O. So 50-50 almost, when you subtract the minor amount from B and AB. But this is what we see with post-thrombotic syndrome, which is very striking. Much less than you would, if it was a random event that post-thrombotic syndrome wasn't related at all to blood group, it's just the luck of the draw and other factors, and it had nothing to do with blood type, you would expect it to be about this distribution, but it's not. It's much less. O positive, 19%, and all of A is 70% when you include A positive and A negative. So it's very beyond random, so it has something to do that's linked. And then when you also include the hypercoagulabilities, you see they're clustered with the A blood types. So here again, in the United States, the distribution between A and O is pretty even. When you look at the post-thrombotic syndrome, it's highly significant. And this, again, is another way of looking at these data. And you see much lower numbers in these blood types because there are fewer people in those anyway. Again, this is a SEEP distribution. You can see that the A-positive people have much more severe disease with their long-term chronic DVT. The A people who have chronic DVT have a certain amount, it's probably proportional. So bad disease is bad disease if you've got it. Now look at this in terms of factor V, protein C, protein S. They're very much clustered in the A positive blood group. So there's some linkage here. So when we're connecting the dots, we know that we have to ask the right questions, but it looks like there is definitely some connection. And then I asked, well, why would this be happening? And I think that when you look at the blood types under a dark field microscope, it's quite striking that you see there's a lot of fibrin in A blood and B blood, and there's really relatively little fibrin in O blood. So fibrin, of course, increases with stress or inflammation or infection. But when you take just a drop of blood from anyone who's not under any kind of adverse circumstance and you look at the blood itself, it's striking how much fibrin there is in A-positive blood types versus O-positive blood types. So it stands to reason there could be a lot more dense thrombus form if you have that much more fibrin in your blood. And so we're starting to some studies can investigate that experimentally. But if you had really dense blood clot formation, then your autolysis ability by secreting urokinase and TPA from your own cellular wall would be significantly impeded if it can't penetrate the thrombus that's there. So if in fact you could predict that when someone with O-positive blood versus A-positive blood comes into the emergency room with a massive DVT, or let's just say a pretty symptomatic iliofemoral DVT that's not totally impeding them, or a popliteal DVT, perhaps we need to be able to say to these people, your chance of lysing this thrombus by yourself, just given standard anticoagulation, is limited. So maybe at that point we need to be more aggressive, and we could select these types of patients for intervention early on instead of letting them wait 6 months to a year to declare the fact that they're never going to lyse their own thrombus. So that's my hope, that this data will lead to some intelligent thinking about being proactive in the clinical area. So with that, I'll stop. Any questions? I know it's provocative, and I hope there are some questions, but that's where I think this research is going. No comments? Yes? Well, we have about 50% of the patients in our group have had a PE. So.
Okay, so yeah, the question was whether you see, because we also know there's a whole bunch there seem to be two types of DVTs. Thinking about it in the simplest terms, there's the kind that don't embolize and the kind that do. And one of the things that's always fascinated me is, why do some DVTs seem so resistant to embolization and others break loose freely? And this blood type hypothesis makes you wonder if some of the same factors that cause you to develop DVT in association with blood clot, in association with blood type, wouldn't it be wonderful if they also cause those clots to adhere more tightly to the veins and have less incidence of breaking loose? That would go along with the idea that
the thrombus stays there.
That it stays there, and that it predisposes, perhaps, could be one of the mechanisms by which you have a higher incidence of post-thrombotic syndrome. is that these are clots that when they form, they may be not only more likely to form, but they just glom on there and stubbornly refuse to dissolve, embolize, do anything else. If that were the case, then one might expect, to really to see a higher ratio of PE to DVT in the O's and a lower ratio in the non-O's.
That's an interesting thought, Tom. Have to look at the data with that in mind, but except for the fact that the majority of these patients with post-thrombotic syndrome are left leg DVT, and a really high percentage of them have May-Thurner, so we end up stenting almost all of them. And sometimes, of course, you can't tell if it's a May-Thurner because it's been clotted for so long, but you suspect that it was. And that should give them some protection against PE in some cases. Like I said earlier in the day, we never know which side the PE comes from unless there's actually thrombus there that looks like, even if it's partially thrombosed in the leg, you can't, there's not a little sign there that says clot recently embolized. I mean, we just don't know where it comes from.
Absolutely agree, but as this presentation has gone on and this conversation has gone on, I'm again been racking my mind and my own long clinical experience, and I'm trying to think of some of my most celebrated post-thrombotic syndrome patients. I can't remember any of them ever having clinically apparent PEs. Again, I'll have to go back and think about this, but the patients who get PEs, I think they're the ones that
You were sending home.
yeah, they're the ones that they resolve quickly and get better if they survive it. They don't, I'm trying to think, maybe they don't go on to develop post-phlebitic syndrome.
Yeah, I know,
often.
and Hal Coons wrote that article a long time ago that said somebody who embolizes is much more likely to embolize. So either you're an embolizer or you're not an embolizer. He wrote that many years ago. Well, do you have any more questions over here? Well, let's go ahead and take a break. Please visit the booths. It's very important that we say hi to the people who are supporting this meeting. And please come back for the 4 o'clock session, which will be a very good session. Thank you.